So, welcome to the Wayside Women's Wellness Echo. If this is your first time, thanks for joining. I'm going to share just a little bit about Project Echo and Wayside Recovery Center as well before we get started. So, first off, Wayside Recovery Center, we are located in Minnesota and we provide mental health and addiction treatment services for women, children, and families. Project Echo, which is the kind of the other part of this, the ECHO stands for Extension for Community Healthcare Outcomes, is a movement to demonopolize knowledge and amplify the capacity to provide best practice care. Together, we have the Wayside Women's Wellness Echo. It's 1 hour long at noon each month. So it's oftentimes over a lot of people's lunch hour. I know it's only an hour, but it's really meant to kind of plant that seed and be a sort of lunch and learn style series with the goal of sharing practice and support service information, which will hopefully enable participating organizations to empower all people in recovery and empower women and families to break the cycle of addiction and trauma. So my name is Zora Darcourt. I'm the Director of Training at Wayside Recovery Center. And today our ECHO session is entitled The Silent Killer, Understanding Stigma in Substance Use Disorder Care. This is the first in a 3-part series on enacting trauma-informed care within SUD services, and I haven't yet posted registration for the next 2 sessions, but those will be coming soon. As of right now, they're scheduled for October 5th and October 26th, and more info to come with those. I'll be sending out registration emails for those follow-up sessions as well once everything's finalized. So our speaker for the day and our speaker for the next 2 sessions as well is Lydia Barthalo. And I'm going to just share a little bit about Lydia and then pass things over. So Lydia is a doctorally prepared psychiatric nurse practitioner with a specialty in addiction medicine and trauma-informed care. She currently staffs and directs a trauma-informed urgent substance withdrawal management center and is on the faculty at UCSF, where she teaches in psychiatric nursing practitioner program. She also speaks nationally on topics such as co-occurring disorders, harm reduction, and substance use disorder care system improvement. And she focuses all parts of her practice on radical public health, harm reduction, and anti-oppression work. So thanks for joining, and I will pass things to Lydia, and I will also get those slides up for you.
Awesome. Thanks so much. I am so excited to be here. I really love talking about this. And I think it'll be a fun day. My plan is to have it be pretty informal. So one of the technical difficulties we've had today is we've had a hard time pulling up slides. So I think Zora's working on that right now. But if we don't get slides, that's totally okay because we can still have a great discussion. So, like Zora said, my name is Lydia Bartholow. I'm a psychiatric nurse practitioner, and I specialize in really how to build substance use disorder services in a more trauma informed way. And it's pretty common for organizations, especially like large hospital organizations, to ask me to come and speak and do consulting work around building substance use disorder services in a more trauma informed way. And I did that for several years. And what I found is that it was really hard for people to improve care systems for substance use disorders and to make those systems more trauma informed when there was sort of this invisible veil of stigma that overshadowed everything. So people would get excited about the ideas around trauma informed care. They would understand the tenets, they would understand the principles, and they'd commit to making their systems more trauma informed. And then I would come back in 6 months, or I'd come back in a year after we had done some work together. I'd done some consulting work, or we had done some training, and we would sort of talk through how things were going in terms of improvement. And kind of over and over again, what I found was that it was really hard to implement trauma informed care. And when we sort of like made our way through the rubble and the debris, usually what the barrier was stigma. And so I designed this really short training on stigma. to help us just start to think about the ways in which stigma against substance use disorders has really informed our thinking, even when we're not totally aware of it. The ways that these sort of like hidden cultural narratives have jumped into our brains, even when we have the best intentions around providing trauma informed care. So I'll jump in today. It's going to go pretty quickly. And I don't have control over the slides, so it might be a little bit bumpy. Bear with me. The last 24 hours have actually been super, super hard. I'm not in my office, so there's horrible lighting here. I apologize. I don't have access to the slides. I apologize for that, although Zora's going to show them to us. And so we're just going to make it through. I think I told you guys a little bit about who I am, but a couple things to sort of highlight here. I live out in Portland, Oregon. I teach at UCSF, so it's often thought that I live in San Francisco, but I actually Zoom into UCSF and live in Portland. And I'm also a person in long-term recovery. So I do a little bit of research, I do clinical work, I do some administration. And when I'm thinking about system improvement from a trauma-informed perspective, I'm thinking as a healthcare administrator, I'm thinking as an academic sometimes, I'm thinking as a clinician very frequently, but I'm also someone in long-term recovery. So I don't just come at this from an admin or academic standpoint. I'm someone who used substance use disorder services. 15 years ago, I was the person giving urine drug screens, and I understand the experience of being asked to pee in a cup in front of someone else. So when I talk about this stuff, it's not just, it also comes from a place of lived experience. So it's not just academic, it's not just from an administrative perspective. I bring that other lens as well. The other thing you'll notice in the slides today is there's a bunch of pit bulls and there's a bunch of bully breed dogs. And at some point, we'll talk a little bit about why that is, why those are included. But we're not quite there yet. All right, so next slide. I don't have any disclosures. I don't work for any pharmaceutical companies. And I think we talked enough about sort of the purpose here. Let's skip this slide too, just for the sake of time. All right, so I want you guys really quickly to see if you can think about, and if you've got pen and paper, or maybe there's like something on your computer where you can just take notes really quick. I want you guys really quickly to try to name as many people from the media that are portrayed positively and either have or are in recovery from a substance use disorder. And when I say media, what I mean is I want you to think fictional characters. So not like Hunter Biden, but I want you to think television, movies. What are the fictional characters that have a substance use disorder or are in recovery from a substance use disorder and are portrayed positively? And when I say portrayed positively, what I mean is they're not portrayed as being selfish. They're portrayed as either able to recover or being in recovery, and their character is not intertwined with criminality. And feel free to put it in the chat if you'd like. I can monitor the chat. But I want you to just take a second and think about who fits in that category. So, fictional character has a substance use disorder or had a substance use disorder, not selfish, able to recover, and not a criminal. Who can you guys think of? Ooh, the main character in Single Drunk Female. Yeah, I need to go back and I need to watch that again. Absolutely. That's a good one. The women on the TV show Mom. Oops, it keeps. Okay, Single Drunk Female, we've got TV show Mom, which I haven't seen. Someone said not all those things. If we need all those things, we can't get them. Sam Malone from Cheers. You know, someone else brought this up at a training last Friday, and I'm so embarrassed to say no one has ever brought that up before. And I don't think I've seen Cheers since I was a child. So I need to go back and watch it because it's been, 20, 30 years since I've seen it. Paul, the wine guy in Friends. Okay, I've never seen Friends. Don't judge me. Coyote from Grace and Frankie. Wow, you guys are coming up with so many good ones that I've never seen or I've never thought of before. I didn't even know that there was someone named Coyote and Grace and Frankie. Was it easy for you guys to think of these? I'm impressed with the ones you're coming up with. Was it easy for you to think of people portrayed positively that have a substance use disorder? Usually the answer is no. Usually it takes a little while to think about this. And there's some interesting things that tend to happen in these conversations when I ask, tell me as someone who's portrayed positively. Usually the first couple things that come up are like house. House is like the first person that people mention here. And that's always such a curious one to me because he's smart, absolutely, and he gets some things done, but he's really selfish, right? And he's not portrayed as someone that's able to engage in recovery. That certainly is not sort of part of the storyline. People also often bring up Nurse Jackie. Yeah, House is both a criminal and selfish. Yeah, absolutely. Um, he's definitely very selfish. That's part of his character is being selfish, and it's intertwined with his substance use disorder, right? People also love to bring up Nurse Jackie, and man, she's such a badass, right? She's such an incredible nurse. She really fights for her patients, and she's incredibly selfish. Um, and it doesn't also portray her as being able to recover. Oftentimes, people can think of a couple, uh, and interestingly enough, they're in the last couple years. So I love that people have been bringing up Sam from Cheers recently because that's older. But usually people talk about Euphoria or they talk about This Is Us. This Is Us is a great representation of recovery and substance use disorders, by the way. But usually they're in the last couple of years. And I bring up the fact that they're often in the last couple of years because what I want you guys to start thinking about is how your brains have been sculpted around media and sort of cultural narratives in terms of what people with substance use disorders are like and what they're capable of. So, how many of you grew up watching Cops? I know I did. And it's easy to think, well, I'm a professional. I understand substance use disorders differently than, is portrayed in the media. And yet these things have sort of seeped in and they've become part of us. And representation of positive folks with substance use disorders or in recovery is pretty hard to find, again, until the last couple years. And that has sort of invisibly sculpted your brains. And I love talking about this because there's just so much nuance here. But the important thing is just when I said, hey, is it easy to think about this? The important thing, several people said, no, it's not easy. And I want you to think about how, when it's not easy to find representation of something, how much that's sort of influenced in this very subterranean way how we think about people with substance use disorders and people in recovery. And again, the purpose here is because we want to implement trauma informed care. But oftentimes, the biggest barrier is that we have these subterranean narratives about who people are that have addiction and who people in recovery are. All right, next slide. So I want to take you guys on a little bit of just a journey of the literature and the research around the impact of stigma on substance use disorders. And those are, I don't actually have either of these dogs anymore, but these two dogs, the black one, that was Shadow. He was a long-term foster. And then the fawn colored pitty, that was my long-term pit bull. That was Chloe, world's best dog. All right, next slide. All right, so this is a pretty old journal article. It comes to us from 2014, and one of the reasons I pull it out is because it was pretty evocative at the time of publishing, and it's been pretty instrumental in sort of the following research around the impact of stigma on substance use disorders. And the reason it was so impactful is that it's a meta-analysis. So it's not looking at sort of a small group of people. It's taking a bunch of data and accumulating it and saying, what are the major findings? So it's taking data from a bunch of different sort of areas, a bunch of different research themes, and saying, what are the sort of underlying themes that really are very meaningful here? And so it's from 2014. So it's got DSM-4 language in it, not DSM-5. So it calls it substance dependence. But it's got a pretty compelling conclusion regardless. Stigmatization was the strongest predictor of substance dependence. And anti-stigmatization prevention and outreach programs are needed to overcome the reluctance of this clientele to use healthcare services. So essentially, what this is saying is that the thing that most prevents people from getting into recovery services, and by the way, getting into recovery services, we know is the number one predictor of engaging in long-term recovery, and not getting into recovery services is how you get into recovery. What it's saying is stigma is the number one reason that people don't engage in recovery services. So the experience people have when they go see a provider, when they go see their primary care provider and they talk about substance use disorders, or even when they go to a substance use disorder provider, the experience that people have that brings up shame and judgment, that's the number one thing that prevented people from engaging in recovery services. And that's kind of a big deal. If we know that recovery services are how people get into long-term recovery, then we want to do everything we can to get people to engage in recovery services, right? And this from 2014 is saying the number one reason people don't engage in recovery services is because they feel stigmatized. And they maybe don't have that language. Not that everyone's running around saying I was stigmatized at my primary care provider, but the emotional experience they have is one of shame, it's one of judgment, and those all fall under the umbrella of experiencing stigma. So this research study was pretty, again, it was compelling, and it sort of shifted the way we started things. Okay, let's try to understand stigma a little bit more. So I want to, show you guys sort of where we've been since there. Next slide. So this next one is much more recent, and I pull this out because I just want you guys to see that, that was from 2014, but still, we're still really talking about this. We're still really thinking about this. And this is from Nora Volkov, and like, she's not a big deal, right? She's no big deal. So it doesn't matter what she says. Does anyone know who Nora Volkov is? I can only see a couple faces. It's hard for me to tell the response here. But when Nora Volkov says something about substance use disorders, like, we don't really care, right? All right, so Nora Volkov, she is the director of SUD. She's the director of substance use disorders and addiction at NIDA. So when she says something about substance use disorders, we take it pretty seriously. And she was pretty directive in this. This was a perspective piece in the New England Journal of Medicine, which, again, no big deal. She's pretty directive. She said stigma not only impedes care delivery, it also most likely causes us to underestimate the burden of substance use disorders in the population. But stigma plays an even larger role in this crisis, one that has been less discussed. When internalized, stigma and the painful isolation it produces encourage further drug taking, directly exacerbating the disease. So what she's saying is, okay, we know that stigma prevents people from getting into recovery services, and we also know that when people experience stigma, that experience of shame and isolation it produces actually neurobiologically makes the disease more intense. So the more we experience shame, the more we experience that painful isolation, the more we experience this feeling of like, oh God, I'll never recover. Gosh, I'm such a piece of garbage. That actually makes addictive disorders worse. And the neurobiology around this is really clear. When you experience shame, you're going to want to use more substances. It's part of why motivational interviewing is all about getting away from shame, right? Motivational interviewing really works because it removes us from shaming and sort of judging and criticizing the patient. It's all about collaboration and affirmation. Okay, so stigma prevents people from getting into services, and also the shame that stigma causes neurobiologically makes us want to use substances more. All right, so we're diving into some of the layers here around stigma. Next slide. This one, and this is getting to be a little bit older now, but it's from the last couple years. This one is essentially saying that people who use drugs, especially people who inject drugs, which I don't know about you all, but injection is, we're seeing rates of injection in Portland, Oregon they're really decreasing. And people are much more likely to be smoking methamphetamines and smoking fentanyl. But the sort of population of the like illicit drug supply, where we're thinking about illicit drug supply versus alcohol, um, that group of people I think is still well represented in this research article. So it's not just about injecting drugs. What this is saying is that people who use illicit substances experience dehumanization in healthcare settings, and so people avoid healthcare for any type of problem. They avoid it because they experience that shame and that judgment and that stigma. That's essentially what this research article is saying. So it really harkens back to that original research saying people avoid healthcare. So when people are using substances, they're going to avoid healthcare services, and healthcare services are the way that people get into recovery. All right, next slide. Hmm. I think there's some missing slides. How super weird. I apologize. We've just had so much weird stuff happen today. One of I think one of the studies that was missing in the slides that I must have sent out, one of the studies that's missing is looking at the sort of structural impact of stigma. And so when I say structural impact, do you guys know what I mean? I'm not talking about buildings, although sometimes it sounds like buildings. When I say structural, what do you guys think I mean? So weird. Whenever someone puts in a new answer into the chat, takes me back to the very beginning. I've never seen something like that happen. Yes. Someone said systems, and someone said larger scale, and someone said from society in general. And that's exactly it. When we talk about structural in healthcare literature, especially around public health, what we're talking about is these invisible systems that influence all kinds of things in daily life. So structural is looking at how policies are written, how funding streams are developed. Structural is looking at things like how racism shows up in healthcare policy, how poverty influences drug use. Structural is looking at all these very, very large things that we know really, really impact the health and well-being of people, but are sometimes sort of hard to see on a daily basis because they're often so big and so invisible. And the term structural really comes from Paul Farmer. How many of you guys know who Paul Farmer is? And someone said institutionalization, structural processes, and related behaviors associated with such. Yes, beautifully said. It's all these big things. Oh my god, okay, someone said I'm not familiar with Paul Farmer. I'm so excited because if many of you aren't familiar with Paul Farmer, you get to learn this amazing new human. So Paul Farmer was a physician And he did a lot of writing about healthcare and healthcare policy in the 70s and 80s. And he just was this brilliant thinker thinking about sort of global health. And he came up with the idea of structure. He came up with the term structural, and he talks about it. And he's really the first person from a research perspective saying, hey, there's these big systems that might influence people's health. And we know that now. So for example, there's been a lot in the media more recently about healthcare outcomes for Black women. And that specifically is nodding to structural forces that impact people's healthcare. So Paul Farmer was the first person to say, hey, we think there's these big structures like, hey, maybe racism that impact people's healthcare, and we should be paying attention to that because it's not just what happens in an office visit. And nowadays we're like, yeah, we kind of know that. But he came up with this term structural and did a lot of thinking around it, and it's pretty brilliant. So if you don't know of Paul Farmer, I'm so excited for you because now you get to learn all about Paul Farmer. So go look up Paul Farmer. And I want us to sort of dive into the 3 ways that stigma show up. And we've kind of gone over some of the literature around a couple of these, but let's dive in and define each of them. So what do you guys think, given what we just talked about structural, what do you guys think structural stigma is? Just think about it for a second, and if you want, you can put it in the chat. Yeah, Caitlin says lack of resources and resource gaps. So essentially, structural stigma is exactly that. It's saying that, hey, when there's stigma around substance use disorders, it's going to show up in a structural way. It's going to show up in a way where there's fewer resources for substance use disorders, or there's resource gaps for substance use disorders. So a good example of this is that I do co-occurring disorder work, which means that I treat a psychiatric concern or a mental health concern along with the substance use disorder at the same time. What has always amazed me is that when I bill Medicaid for a substance use disorder, my revenue is $30 less than if I bill under a psychiatric disorder. What? That's bonkers, right? I'm still spent 30 minutes with someone or 20 minutes with someone. And yet, that's such a clear example of the way in which we prioritize mental health concerns over substance use disorders, and creates this structural system where people are going to be less likely to treat substance use disorders and more likely to treat psychiatric concerns. So that's an example of structural stigma where there's these like resource gaps, or where there's sort of funding streams that show up in ways that deprioritize people with substance use disorders. I think a lot about the fentanyl crisis, and this feels very sort of personal today. I lost a old coworker to a fentanyl toxicity or fentanyl overdose yesterday. And I think a lot about the way in which, if there was a public health concern that was killing people at the rate that fentanyl was, we would be doing everything we could to stop it. And yet we're not following some of the very best, most pertinent public health research for best practices for a public health epidemic like this. And that's all about structural stigma. That's because the policies aren't informed by the public health literature. They're informed partially by structural stigma. So that's what structural stigma is. Yeah, and someone said maybe include stigma in policies. Absolutely. Absolutely. Structural stigma is when stigma shows up in policies where we don't follow best practices. We follow these old stigmatized beliefs around people who have substance use disorders and what it is that helps them or stops them from using. Absolutely. So, interpersonal stigma is built and connected to structural stigma. And interpersonal stigma is something that showed up in the literature, but we didn't call it interpersonal stigma. What do you guys think interpersonal stigma is? And once again, when you put a comment, the new message, yeah, judgment, it somehow kicks me back to the very top. Judgment, that's absolutely correct. So Caitlin said judgment, and that's 100% what it is. When we talked about the literature that said that people experience dehumanization, that's the word that the researchers used in healthcare settings, that's interpersonal stigma. It's when, especially when someone who's supposed to be there to support you, like a healthcare provider, judges you, brings up feelings of shame, or treats you poorly. And how many of you guys see interpersonal stigma affecting your clients right now? I don't know about you guys, but my patients go to the emergency room and are sometimes treated really poorly. Or maybe the primary care provider really didn't mean anything, but it actually super impacted my patient when the primary care provider said, "Oh, I never give refills on a medication like that." Because what the patient heard was, "You think I'm still an addict and I can't manage this." So people experiencing stigma in their day-to-day life is what interpersonal stigma is. And again, that's built partially on structural stigma. If we have these like large cultural narratives that show up in these huge structures and stigmatize people who use substances, of course, that's going to be replicated in just these day-to-day interactions, right? If we have um, narratives of people who use substances and they're not very positive and they're not sort of based in the evidence, then that's going to show up in a primary care visit, or that's going to show up when there's a police officer interacting with someone with a substance use disorder. That's what interpersonal stigma is, and it's one type of stigma that's incredibly powerful. And that interpersonal stigma then gives way to self-stigma, and self-stigma is something we talked about in the literature. What do you guys think self-stigma is? Oh, Margot says that you guys go to the ER with clients, because of interpersonal stigma. Yeah, absolutely. That's the kind of thing I see on a daily basis, and that is interpersonal stigma. That's stigma showing up in a care setting. I'm so glad you guys go with your clients. That's so beautiful. And then in terms of self-stigma, Christina and Caitlin said low self-esteem and negative self-talk. And that's absolutely right. If policies and laws and funding streams say that this person or this group of people isn't worth as much as another group of people, and then you're treated poorly by the ER physician or the primary care provider or even your alcohol and drug counselor, you are going to internalize narratives about yourself that are not great, right? That are like, I'm a dumb addict, I can't do anything right, I can't recover. And I think this is one of the really useful reasons to talk about and think about narratives that show up in the media. And I partially mention this because I remember the first time I saw myself reflected back in media. I had never seen someone in recovery before. I had never seen someone shown in a television show or a movie that was in recovery or used substances that looked like an okay person. So I didn't have any way to know if I was okay. Right? I didn't have any way to there was no representation of me to say that, like, I could recover and that I wasn't selfish and I wasn't horrible. And the very first time I saw it was on West Wing. How many of you guys have watched West Wing? And I remember crying because there was people in recovery that were good and smart and useful. And I remember thinking, "Oh, that's me." And yet it also very much wasn't me, which we'll come back to in a second. But I wanna just wrap up really quick on self-stigma and highlight again that the neurobiology of self-stigma says that it propels substance use. The more self-stigma we have, the more likely we are to persist and continue our substance use. And of course, all of these 3 things are deeply intertwined. One doesn't exist without the other. So we see stigma showing up in these really big ways and these really small ways, and all of them are intertwined and exist because of the other ones. So those are your 3 types of stigma, and now that you are aware of them, you're gonna see them everywhere. You're gonna see, "Oh, that's self-stigma showing up, that's interpersonal stigma, that's structural stigma." You're gonna see it all the time, and probably some of you were aware of these 3 layers, but if you weren't before, you're gonna see it constantly now. Alright, next slide. Okay, so let's go back to that initial exercise that we did, where we thought about people who are portrayed positively, they have a substance use disorder, and I want you to see if you can think of folks that are people of color. I I was really impressed with what you guys came up with. Ooh, yeah, Euphoria. I was impressed with what you guys came up with the first time, so I think you're gonna be pretty good at the second one. Euphoria is a great example. If you haven't seen Euphoria, recommend it, although it's an intense watch, definite, sort of content warning there. Samuel Jackson. Yep, triggering for sure, Christina says, speaking about Euphoria. It's great, and, your ego strength needs to be high when you watch it, absolutely. Samuel L. Jackson, yeah, I'm trying to think of a fictional character where he's portrayed someone positively with a substance use disorder. Is he in recovery? Samuel Jackson? I don't think I knew that if he was. Flight? Wait, is the flight comment? Oh, Denzel. All right, I'm getting lost in the comments here. But what hopefully you're noticing is that it's even harder to find representation of people of color. So, for example, when I watched West Wing, I was like, "Oh my god, finally, there's someone representing recovery in sort of popular media." And also, these are, wealthy white men, which doesn't reflect my experience. And I want you guys to just think for a second about how that influences these kind of subterranean narratives that we have about addiction, who people are with substance use disorders, and whether they can recover or not. So, the point of this exercise here is for us to just think about how stigma sometimes can be multi layered. And what the research is very clear about is that people of color experience stigma in healthcare settings even more intensely when it has to do with substance use disorders, which I think is on the next slide. Yeah, and Courtney says often in media, people of color are portrayed negatively when it comes to SUD, and that's absolutely accurate. Again, this is a great time to mention Cops. When I was a kid, we watched Cops on a pretty regular basis, and what I got to see was people of color being arrested and criminalized for substance use over and over and over again. And so, again, many of us have amazing knowledge about substance use disorders. Someone said, I don't watch commercial TV, which I absolutely love. I think that's amazing. And the point here is that there's these kind of hidden narratives that sometimes show up. And that is especially intense for folks of color. So, when researchers have looked at perceived barriers to engaging in SUD care for African Americans, it's very clear that there's these structural and these interpersonal factors that show up. And there's more barriers to engaging in care for folks of color. All right, next slide. So, before we dive into these sort of final takeaways for today, I want to just spend a second thinking about kind of what we just did. So, we talked about sort of media representation, and then we looked at some of the research and the literature around how stigma impacts health outcomes for people that use substances or have substance use disorders. And I wonder, sort of what you guys make of that. Like, does it seem useful to review popular media representation and think about how that impacts health outcomes? Think about it for a second and feel free to put something in the chat if that's useful for you. Sometimes it's nice to sort of process out loud or in chat. And another way to think about this is, what's the point? Why did we just do that? Why did we just look at popular media representation of addictive disorders and then also contrast it with the literature around the impact and the role of stigma. Ken says, I agree. This is what I do with my clients regularly. I don't like the word addict or alcoholic and the like. Ken is already looking at our actionable takeaway. Good job, Ken. You're one step ahead of us. All right, since Ken has taken us there and this is sitting on the screen, let's just dive into it. So, I want to give you guys some really, really high quality research around language as your actionable takeaway. And when I do that, I do it because I want to acknowledge that those of us in this room, we're not necessarily going to be the people to tackle structural stigma. Although part of our job as people that tend to people with substance use disorders is to fight structural stigma on a daily basis. It's to fight interpersonal stigma on a daily basis and help make sure that we don't stigmatize and judge people and um, increase their personal shame and stigma. And part of the way that we can do that is we can choose recovery promoting language, or we can choose language that we know is evidence based and increases stigma for people with substance use disorders. So, actionable takeaway is how we talk about substance use disorders. And I'm going to just break down this literature really quick for us, and then we can pivot over to questions. So, the first thing I want to do here is I want to highlight that the image that you're seeing on the screen, this is not someone's opinion. This is really, really high quality research that shows that certain words increase negative assumptions and judgments about people who use drugs or have substance use disorders. And there are certain words that decrease stigma. And of course, decreasing stigma is what we want. Hopefully, what you got from this talk today is that we want to decrease stigma. So, what the researchers did is they told the same story over and over again, hundreds of times to a variety of different people, and they switched out words. And then they asked what value you put on the person in the story. So, for example, John relapsed on Friday. On Sunday, he saw his provider for a buprenorphine script. And on Monday, he visited his child. And then they told the exact same story, but they used slightly different language. And then they asked, is John a good person? Would you try to help John? What would you do for John? And what they found is that language was really, really instrumental in how people thought about John, which is actually kind of a big deal. So again, it's not someone's opinion. It's saying, hey, these words um, change how we think about people with substance use disorders, which is what we really want to do. We really want to change how people think about people with substance use disorders positively, right? The other thing that the researchers did is that they said, hey, it's appropriate to say some of these words in some places, but not appropriate in others. So a lot of times it's like, oh, you shouldn't say that word. And I want to tell you guys, I'm not here to be language police. You know what the worst thing is? It's for someone to get caught on a word and lose track of the meaning of what I'm trying to say. I never police people's language. I certainly don't police people's language and how they self narrate. So, what you'll see is you'll see there's a little slide here, or a little column for mutual aid meetings. And there's a lot of things that are totally appropriate in a mutual aid meeting that then aren't appropriate over here in medical settings. So, for example, if I go to a 12-step meeting or I go to a refuge meeting and I say, I'm Lydia and I'm an addict, you know how awful it would be if the whole room turned to me and said, Lydia, technically, we don't say addict anymore, right? So, this is not about policing language. For me, this is all about how I have changed my language. So, I try to talk differently in a medical setting based on the evidence. I don't try to tell people that the words they're using are wrong. For example, if I have a client that comes in and says, I relapsed over the weekend, I don't say, well, technically, we don't call it relapse. What you had was a return of use, right? The client just shared something really vulnerable with me. I'm not going to sort of shut them down and miss the content of their message, and prioritize correcting their language. So just for the sake of things, let's focus in on medical settings because um, many of us are in medical settings. So let's go through medical settings. What is evidence-based in terms of promoting recovery and decreasing stigma and what's not? So addict, alcoholic, those are out. They're not person first. So we would say someone with an alcohol use disorder or someone with a substance use disorder, someone with an opioid use disorder. And most of you probably know that. We use person first language in healthcare settings. We try not to say schizophrenic. We say person with a diagnosis of schizophrenia. Sometimes, though, the next one down is a little bit harder. So we try really hard to avoid the term substance abuser or substance abuse. And why might we avoid the term abuse when we're talking about substance use? Yeah, violence. Caitlin said violence. We don't use the term abuse to talk about substance use any longer for two main reasons. One is um, think about who abusers are. We've got, spousal abusers, child abusers, animal abusers. Those all involve violence and harm. Lots of people use substances and don't engage in violence, which is not to say that addiction and violence don't sometimes go together, but it's not a core element of a substance use disorder that there's violence. So we try not to say abuser. And the evidence is very clear that abuser or abuse increases stigma. The other thing is especially in a medical setting, is substance abuse a medical diagnosis any longer? It's not. We removed it when we moved to DSM-5. We don't talk about substance abuse anymore. That doesn't mean anything. When someone says substance use, I don't know what that means. It doesn't have very much utility from a medical perspective. Let's keep going down and highlight relapse really quick. This one was so hard for me to unlearn. I have been saying relapse for 20 years. And this evidence, again, where they told narratives and then asked about the value of the person in the story, relapse actually increased stigma and decreased the value of the person in the story. And so, what the researchers came up with was that the terms return to use or recurrence of use were preferred. So, if I'm charting on a patient, I'm going to chart there was a return to use. Doesn't mean I correct the patient if they tell me they relapsed, but I'm going to chart it as return to use. The next one that often sort of surprises folks is medication assisted treatment. You'll notice that across the board, we try to get away from medication assisted treatment. Any ideas on why that might be stigmatizing? It's kind of a tricky one. And I'm almost out of time, or I would talk about it for a really long time, but I'll just dive in really quick. So medication assisted treatment, we try to avoid. And the primary reason for that is that medication assisted treatment sounds like the treatment is something other than the medicine, and the medicine just helps out for a short period of time. And what we know is that medications, especially medications for opioid use disorder and alcohol use disorder, they are the gold standard part of an integrated treatment response, right? It's not that 12-step spiritual work is the treatment and we assist that with medicines. It's that multiple paths to recovery are totally appropriate. And medications can even be the central part of someone's recovery. So instead of medication assisted treatment, we say medications for addiction treatment. ASAM came out and said, oh my God, what do we do? Medication assisted treatment. We now consider that to be not evidence based language. But gosh, MAT is everywhere. MAT is in our policies, it's in clinic names, MAT, you're going to see that acronym everywhere. And so we're just going to say it's medications for addiction treatment. Just like we would say antidepressants, antipsychotics, these are medications that help out in addictions. Boom, medications for addiction treatment. But we try not to say medication assisted treatment. And I love this graphic. It'll be in the slides from today. And I just hang it up whenever I sort of move my clinic or move offices. I just hang it up so people know sort of why I use the words that I use, that my colleagues know why I'm using the words that I use. And I make a point to not interrupt them or to correct people's language, but just to sort of model and show this is how I talk. Because I think stigma is one of the primary things that gets in the way of really, really high quality substance use treatment. And I bring us back around to that point because the next two sessions, I'm going to talk to you guys about enacting trauma informed care for substance use disorders. And in my experience, if we carry stigmatized narratives, we're much less likely to hit the mark of trauma informed care. If we carry these hidden stories about who people are with substance use disorders, it's going to be much harder for us to engage in collaborative treatment with people or to um, engage peers in a truly meaningful way. And those are two tenets of trauma informed care: peers and collaboration. So if we carry these stories, we're not going to be able to do the trauma informed care stuff. So that's why I always start here with a grounding of, hey, here's how big stigma is. It impacts people neurobiologically on a personal level. It impacts what people experience when they come into care on an interpersonal level. And it impacts almost everything we don't see about people getting into services. So we've got just a couple minutes now for questions. What questions do you guys have about this idea of stigma?
And feel free to unmute too.
Yeah.
Ask questions, or I can read the chat. I'll also stop recording here so that everyone feels comfortable.